Hello, I'm Sarah Rodriguez, and today I am going to be presenting on gas gangrene, which is also known as Clostridium myocrosis. It is of the domain of bacteria and the genus Clostridium. It is a gram-positive bacilli facultative anaerobe, although it grows better in more anaerobic conditions than anaerobic conditions. It contains endospores and is encapsulated. And there are a couple of different strains. Perfringens is the most common strain. It makes up about 80 to 90% of gas gangrene cases. Myocrosis is a very historically common war infection, and specticome is the most common strain to cause spontaneous infections. Sordelli is one of the more rare, uncommon strains. It is more recently identified or known to lead to gas gangrene of the uterus, and is more recently discovered or suspected that it is associated to black tar heroin injections. Now, it was discovered by William H. Welch in 1891. He was a pathologist who discovered the cause to gas gangrene. It was also more prevalent in World War I. Even though they knew about it before World War I, it definitely reared its ugly head during World War I. This was mostly because of trench warfare. So, because gas gangrene is anaerobic and more likely to be found in manure, it grows really, really well underground. So, when they built the trenches, they brought all the Clostridium up to the surface, which then interacted with soldiers' injuries and infected them. Which also didn't help that most of the injuries from the World War I were not very clean. They were always really dirty and full of dirt. And Dr. DePage was a Belgian physician during World War I. He was one of the physicians that reintroduced a French technique into treating gas gangrene, which was also known as debridement, which was where they took away the necrotic tissue, and allowed the healthy tissue underneath to heal itself. There was also a French anti-gas gangrene serum that also existed during World War I, although it had very, very little effect. You can see a picture of it in the top right. The Clostridium organisms produce many exotoxins. These exotoxins also produce the gas, which is how it's gotten its name, gas gangrene. The alpha toxin is the most common, most prevalent toxin, the most toxic toxin. It constricts the blood vessels and clustering platelets. It interferes with neutrophil recruitment and activates the protein kinase C. Another very common or very important exotoxin is the theta-toxin, which mostly just slices the cell. Perfringens, the strain Perfringens has almost like 17 toxins, produces almost like 17 toxins. The way this actually works is that the Clostridium produces toxins, and the alpha toxin more likely it inserts itself into the cell membrane and disrupts the function. You can see this in the picture on the right. It inserts itself, it goes through the basal membrane and basically just destroys the membrane and produces gaps in these blood vessels down at the bottom. Yeah. And then that leads to the extensive tissue necrosis. Now, nowadays, the gas gangrene is not as prevalent as it was even like in Vietnam or definitely world wars. Currently, there is only about 1,000 to 3,000 cases per year in the U.S. If you get immediate care, the fatality rate is really only about 20 to 30%, and sometimes it can be even as low as 5 to 10. If you get no treatment whatsoever, then it is 100% mortality, 100% mortality rate. It is also seen more in adults between like 30 and 50 years old. There is there was a big decrease of cases throughout the wars, the American wars. From World War I to World War II, there was only a small decrease, but from the Korea War and during the Korea War and the Vietnam War, it decreased all the way down to a 0.016% incidence rate and 36% fatality rate. The mortality rate also decreased since they came out with exotherapy. In 1928, there was a high mortality rate, but more recently, semi-recently, in 1940, they significantly decreased their mortality rate. Now, really the only way for gas gangrene to be transmitted is through direct contact, or more likely a vehicle transmission. This is more likely because of contaminated medical instruments and gloves going from physicians going from patient to patient. Now, the main way to prevent gas gangrene is to clean skin injuries, prevent dirt from getting in, and also from the airing injuries out so they are introduced to the air, especially because gas gangrene is an anaerobic bacteria which would love the limited air supply. Another way to prevent it is to watch out for infection, and as soon as you see infection, you go immediately to the doctor. Now, a couple of symptoms are most patients present with fever, chills, pain, inflammation, but not as much superficial inflammation at the site of infection as one would think. Discharge from the site of infection. This discharge will look more like dishwater-like and have a musty smell. And there's also some blisters that form at the site of infection, and the skin color goes from pale to a dark red and purple color. Also, another symptom is gas under the skin. As I said before, it produces toxins which then produce gas, and you can see the gas in the dark area on the picture at the top. A couple of ways that they diagnose it is through immediate blood and culture tests, CBC, CMP, and an AGB. These are all a bunch of different blood tests counting blood cells and such like that. Another really great way is through imaging tests, such as X-rays and CT scans. These are, they help them see and identify the extent of the infection and if there's gas and how much gas there is at the infection site. In this picture, you can see at the red arrow, you can see at the red arrow, it shows all these dark spots. That is where gas has been released, and that is how most people, a bunch of times they diagnose it that way. Another good way is through deep wound aerobic and anaerobic cultures. If you do these cultures at the time of the initial debridement, it helps identify the causative organism and also direct antibiotic treatment. Now, there are a couple of ways to treat this, or all of these ways are really great ways to treat gas gangrene. And most often they have to all be together to be effective. You want a really aggressive treatment. Antibiotics, you want to start those immediately, even before you get any of the cultures back, because this infection goes really, really fast and creates necrosis tissue very quickly. You want to start with broad spectrum, but if you are definitely positive that it is caused by Clostridium, you want to use penicillin combined with sildenafil. I don't know if I said that right. Surgeries, you definitely want to do surgeries. Combine antibiotics with surgeries. Fascitotomy is a way to relieve the tension. Debridement, we said before, it helps get rid of the necrotic tissue and let the healthy tissue come to the surface and heal. Another treatment is hyperbaric oxygen therapy, though this is a little more controversial. It's not a definitive treatment, but it basically is where they put the patient in this chamber. So you can see on the right hand, this is the hyperbaric oxygen therapy chamber. So they put the patient in the chamber, and then they surround them with a ton of oxygen, pure oxygen. And the hope is that it will halt exotoxin production and improve the bactericidal effect. Now, the future, there wasn't a whole ton of information about what they're planning on doing in the future, though I suspect that, and it also isn't a very, it isn't as common. It's still pretty rare now, now that they have figured out a way to keep wounds clean, and if they come in contact with Clostridium organisms, they know of a way to aggressively treat with antibiotics and surgery. But I would suspect that they would probably look into more closely into why it spontaneously, why there's sometimes spontaneous infections, or more closely into what the toxins actually do. And then here are my resources. I'm looking forward to some questions in class.